From the JAMA Network, this is JAMA Clinical Reviews, interviews and ideas about innovations in medicine, science, and clinical practice.
Hello, and welcome to this JAMA podcast. I'm Dr. Linda Brubaker, a senior editor at JAMA. Today, our guest is Dr. Susan Reed, who is a professor emeritus at the University of Washington. She is currently the president and CEO of the Menopause Society. Welcome, Dr. Reed.
Thank you. Pleased to be here.
Your contribution, Nonhormonal Therapies for Menopausal Vasomotor Symptoms, really describes new information that's very relevant for clinicians who take care of individuals who are in menopause. Let's start with just a quick review of the magnitude of vasomotor symptoms. How many people are affected, and what's the magnitude of their symptom bother?
Thank you. Sure. So what we have seen literally in the last year is what I'm calling a menopause renaissance and an understanding of the impact of the symptoms that occur with the endocrine changes of menopause at midlife. And we know that approximately 1 billion people experience menopausal symptoms globally at any given time. So half the world's population is female. And so the magnitude of this problem is tremendous. About 80% experience vasomotor symptoms, but there are other additional symptoms of menopause, and we see it affecting relationships, work. We know that probably up to 75% of individuals will have to miss work because of symptoms related to menopause. So we are seeing I think, a wonderful recognition that our patients are needing more from us as providers, and they're wanting more from society in recognition of the symptoms that individuals experience at midlife.
Let's talk a little bit about our evolving and improved understanding of the cause for vasomotor symptoms.
Sure. So this is why I was just so excited to be asked to write this article, because in the last several decades, we've really seen some novel research in our understanding of what causes vasomotor symptoms. Historically, we've understood that it was the diminution of estrogen at the time of menopause that fed back to the GnRH neurons in the hypothalamus to result in vasomotor symptoms, but there wasn't a good understanding of why that happened. Today, we now know that there is a group of neurons, and we call them the KNDy neurons, K for kisspeptin, N for neurokinin B, D for dynorphin, that are literally adjacent to the GnRH neurons, and that we really think are the controllers of the pathophysiology of hot flashes. They are immediately adjacent in the hypothalamus to the thermoregulatory center, and it is the crosstalk of these controlling KNDy neurons that will result in what we're calling a dysregulation of the thermoregulatory center and then subsequent hot flashes.
So this new understanding obviously opens up some opportunity for new therapeutic interventions. Is that how this new class of medications began to be considered?
Exactly. So super exciting. As this audience well knows, with the information from the Women's Health Initiative, there was a huge movement away from use of hormone therapy for individuals with symptoms. And some of that movement was misguided, quite honestly, because what we understand today is that menopausal hormone therapy for individuals 50 to 59 is relatively safe in healthy individuals. So menopausal hormone therapy does continue to be our first line therapy for significant vasomotor symptoms and menopausal symptoms for individuals without contraindication to hormonal therapy. For the reason being, hormonal therapy in individuals ages 50 to 59 is also helpful for heart, bone, and brain in addition to symptoms. However, for those individuals that are unable to take hormone therapy or have aversion to taking hormone therapy for their own personal reasons, We absolutely need a safe and effective non-hormonal treatment modality. And our patients have been asking for this for decades. So it's what I call a watershed moment. We are now targeting the area in the brain that we understand is responsible for vasomotor symptoms, whereas we were kind of shooting in the dark a bit with our non-hormonal therapies prior to the understanding of this new class of drugs, NKB antagonists.
So once the estrogen withdrawal occurs, it's my understanding then that there's hypertrophy of those hypothalamic neurons. And then what happens?
Yeah, that's exactly right. So these hypothalamic neurons, these candy neurons, get massive. They're huge and they literally go into hyperdrive or overdrive. And it is the neurokinin B that the candy neurons express and secrete that cause this magnification, if you will, of the activity of these neurons. And these neurons then communicate with the thermoregulatory center through their synapses. And it's this hyperdrive or overdrive that we believe is stimulating the thermoregulatory center in a way that is not great for our patients, resulting in hot flashes.
So there's a very, very clear biologic basis. It's not an imaginary symptom. It's very clearly biologically based. Yes?
Exactly. And so, again, to me, as a scientist and researcher, it is so exciting to see treatments linked to what we understand as to the biology of a process. So, this is, again, super exciting and has huge potential.
Well, let's talk about the new therapy a little bit. How does it work?
So, neurokinin B antagonist. So, I just spoke to the fact that it's the neurokinin, and it's actually the NK3 receptor, that when neurokinin B attaches to the NK3 receptor, we see an increase in the activity of these candy neurons. But when we have an NKB antagonist, such as the product called fezolinetant that was just FDA approved in May of 2023, when that antagonist rests on the NK3 receptor of the candy neurons and perhaps also in the area of the thermoregulatory center, we don't really know, is the NKB antagonist sitting on receptors in both of these hypothalamic areas, that we see a shutting off of or tuning down of the hyperactivation of these neurons. And no longer should we experience the hot flashes or vasomotor symptoms. So it basically turns down or turns off the system that was in hyperdrive.
So, does it return it to a normal thermoregulatory process, or are people who are on this medicine less able to do thermoregulation?
So this is an excellent question, and we're still in the process. So as I say, I'm super excited about these medications, but we're still learning a lot about them. Can it completely turn off the entire system? I think the answer to that is going to be no, because of the complexities of how the human body functions. We always have little ways or little systems that an individual's own physiology or chemistry will vary from the person sitting next to them. And it's that complement of the physiology of what's happening in the hypothalamus for an individual that will determine how well these medications work. So we saw promising results with this new medication, but it's not appearing that it's going to be 100% for everybody.
How is the medicine prescribed? What's the dose? What's the route?
So it's a daily pill, oral. And as we know from what's called phase 2 studies, where we're looking at dosing studies, to what was recently published, phase 3 studies that look at efficacy and safety, that the phase 3 trials looked at 2 doses, a 30 milligram tablet and a 45 milligram tablet. And it was recognized that we are not seeing sufficient efficacy with a 30 milligram tablet, that it is the 45 milligram tablet that we started to see some nice statistical significances in the frequency and severity of hot flashes in some of these phase 3 clinical trials. What we do know from the phase 2 studies, these dosing trials with higher doses of the fezolinetant, it does appear that there is a dose response for the ability of the medication to quell or decrease hot flashes. But as the doses of this class of drugs are increased, we start to see some changes in liver function tests. So the developers of this medication need to balance the safety and the efficacy of the product for use in large populations.
Can this medication be given at the same time as oral menopausal therapy, estrogen or progesterone?
That's a great question. That is unknown, but I would also say that it's hard for me to imagine a really good reason for that right now. Until we have more data on safety and efficacy for this new class of NKB antagonists, these are only recommended for individuals that have contraindications to menopausal hormone therapy.
So once a clinician starts a patient on this, what monitoring should be occurring to optimize the safety for that patient?
The NKB antagonists are contraindicated in individuals with severe liver or renal disease, and that the FDA is recommending that all individuals who start the new medication should have a baseline evaluation of liver function tests and to make sure that they're normal at the outset of treatment. And then liver function should be assessed every 3 months for a full 12 months.
When can a patient expect to see efficacy if the medication will work?
So this is another exciting thing that we know about, in general, our non-hormonal therapy. So for the new NKB antagonists, we start to see efficacy as early as 1 week, 1 to 2 weeks. The data looks really good. So the hot flashes really decrease rapidly. We see similar rapid responses with the SSRI, SNRI non-hormonal therapies that we've been using off-label now for decades. Within several weeks, we see a response usually.
And we anticipate that this FDA approval will help with insurance coverage. We also recognize that not every patient has health insurance, medical insurance. Could you talk a little bit about the cost with a special note to those who may not have ideal health coverage?
This is an important area in all drug development. And I think particularly in this situation, we know that some underserved populations, Black and Hispanic populations, have a higher risk to have longer duration of hot flashes and more severe hot flashes. So they're less likely to have access to insurance for these types of medication. Wholesale cost is around $550 per month. And so you're looking at over $6,000 per year, which is prohibitive for many individuals. And that with insurance, the estimate is around a copay of $67 per month. That again is not trivial. So once again in medicine, we're in a situation where we see vulnerable populations disadvantaged. I would go on to say that it is so important that these medications be made available for those at risk for, or those with a breast cancer or a blood disorder that results in lung or leg clots, because we know that breast cancer and clotting disorders are contraindications to systemic estrogen, and these patients are especially good candidates for this new menopausal treatment. We know that mortality for Black individuals with breast cancer is around 40% higher than that for white individuals, and that Black populations are disproportionately affected by breast cancer. Therefore, it's imperative that these people have access to medications that have the potential to provide them with a better quality of life.
With this new development, it's a wonderful breakthrough for patients, but I suspect they're demanding even more. What's your opinion there?
We are seeing that patients' voices are being heard certainly by the media. So in February, New York Times did a piece on menopause. Oprah had something on her show in April. And even the U.S. House of Representatives brought forward a bill to compel the National Institutes of Health to evaluate the status of menopausal research, identifying gaps, and to devote more money to research in 2023 and 2024. We know that our patients are telling us that our providers are not always receptive to discussions around symptoms of menopause, that we know from surveys that not all providers feel comfortable with treatments for menopause. So we have a long way to go to not only improve access to effective and safe medications, but to help our patients make good choices, to educate our providers so that they can guide them in a shared decision-making process that is using evidence-based information. Lastly, I would say is that we know from surveys of menopausal women, around 80% feel that their best information about menopause is from social media sites or from their friends or their families. And we as providers need to do better to provide simple messages for our patients and to help guide them toward sources of information that are accurate.
Thank you very much. We really appreciate your expertise and your contributions and for spending time with us today. Our listeners have enjoyed this conversation with you about the non-hormonal therapies for menopausal vasomotor symptoms and the new medication that's now available. I am Dr. Linda Brubaker, Senior Editor for JAMA, and I've been speaking with Dr. Susan Reed about the new medication for menopausal vasomotor symptoms. You can find a link to the paper in this episode's description. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com or search JAMA Network wherever you get your podcasts. This episode was produced by Daniel Morrow at the JAMA Network. Thanks for listening.